Okay, well, we'll get started. Thanks so much for joining today. I'd like to start by acknowledging the traditional owners of the lands from which we're all joining today. I'm joining from the lands of the Boonwurrung people of the Kulin Nation. I pay my respects to elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people with us today. So I'm Professor Dennis Petrie. So I'm a middle-aged white man with brown hair and a beard that is quickly going grey. I'll start with some accessibility and other housekeeping issues. So we've got live captions today. So in the chat, there should be a link for the live captions that you can use. It's also pinned to the top of the chat, so it can be found there. We've got Auslan interpreters with us today. So there's 2 interpreters with us today, and they'll switch at different times to give themselves a break. And so there should be spotlighted in the videos, and if you click on them, you can make them bigger compared to the shared screen. You can also pin people. So if there's particular people talking, you can pin them by right-clicking and selecting pin, and you can also click on them to make them bigger if that's helpful for you. So if you need help during the meeting, please message our tech host in the chat, or you can also email dwi@monash.edu. Okay, so I might get to the next slide. So welcome again to the Disability Wellbeing Index launch. So I'm Professor Dennis Petrie. So I was involved in the Disability Wellbeing Index project, which led to its development. I also co-lead an NHMRC Centre of Research Excellence in Achieving Health Equity for all people with disabilities. So I suppose large part of my focus is on understanding the impacts of different policies and services and supports on people with disability, and to try and maximize outcomes for people with disabilities with the available resources. So we might move on, gang. So I'd like to acknowledge a number of people who have been really important in making the Disability Wellbeing Index come to fruition. So I'd like to thank NDIS participants and their supporters who assisted participants with survey completion and also responding by proxy for sharing their views. The significant, keen and welcome participation of adults and young people with disabilities in reviewing and refining the Disability Wellbeing Index produced a better outcome that wouldn't have otherwise been possible. We'd like to also express our gratitude to people with disability, representatives from disability representative organisations and disabled people's organisations, as well as policymakers who provide valuable feedback on the development of the Disability Wellbeing Index. The creation of the Disability Wellbeing Index was funded by the National Disability Insurance Agency, which we're thankful for. We're also grateful for their support, in particular, Dr. Andy Goodall, Dr. Vivian Howe, Dr. Aaron Blanco, Dr. David Cullen, and the NDIA Evidence and Practice Leadership Branch for valuable discussions and support for the project. Okay, so the Disability Wellbeing Index came about from lots of collective effort, and that also included a large research team. So we had partners from Monash University, the University of Sydney, and Flinders University, a number of really important contributions from a large number of people. I won't go into all of them, but they all played an important role in making the DWI what it is. Okay, so the outline for today, first off, we're going to get the NDIA opening remarks from David Kay. Then we're going to go into a bit about the motivation for developing the Disability Wellbeing Index. Then we're going to talk about what is the Disability Wellbeing Index and its development. Then we're going to talk about accessibility considerations. We're going to compare how it does versus other social care quality of life measure. Another social care quality of life measure. Then we're going to talk a bit about the website that we've developed and also the user guide. And what I'll also remind you is that they'll then have a Q&A session. So the Q&A button should be at the top of Teams, little question mark in a bubble. And so throughout the talk, I'd encourage you to put your questions, comments, suggestions into the Q&A. There'll be people who might answer that during the talk as well, but we might also then come back to those questions at the end of the presentation to kind of open up discussions a bit more on those questions. So yeah, so please remember to fill in those questions and put your comments in as well. We want to make this as interactive as possible. So we might move on to our first speaker. So that's David Kay. So David is a strategic advisor in the Policy and Practice Leadership Division of the NDIA. He's leading the work to develop a new NDIS outcomes framework, which will define and measure the outcomes for NDIS participants, government, and the community more broadly, from investment in and support delivered through the scheme. So I'll pass it over to you. Thanks, David.
Thanks, Dennis. Yeah, as Dennis said, I am a strategic advisor in the Policy and Practice Leadership Division at the agency. And I'm here today representing the agency, and we're really pleased to be here at the launch. I'm also a middle-aged white male. I have brown hair and a grey beard, and I'm wearing a blue jumper. We've had the pleasure of working with and supporting Monash over the past few years on the development of the index. We first started working with Monash back in 2021. And at the time, there was no validated tool that was available to us to measure the well-being of NDIS participants. And we saw the value and the need to have a kind of simple and preference-based tool that was designed with the Australian context in mind. We're really pleased that the tool has been finalised and is being launched today. In terms of what the agency is doing, so we're looking at how we can utilise the DWI in our own outcomes measurement processes. And we're doing this as part of a refresh of the NDIS outcomes framework. Some of you might be aware that we have an NDIS outcomes framework. We've had a framework in place since 2016, and it focuses on participant outcomes in different life domains, which are similar to the domains that the DWI encompasses. The NDIS has evolved and matured since that outcomes framework was put in place. And it's important that we do this refresh now so that we can capture the outcomes that are important to participants now and going forward. So we're looking at how we can use the tool, the DWI, either as part of outcomes measurement processes, which might be alongside questionnaires that we utilise to measure outcomes from participants, or integrated into those questionnaires. So that's something that we're working on currently. I guess finally, from a broader perspective, I think the agency is very pleased that the tool has been developed and can be used not only for NDIS participants, but for people with disability more broadly. And we certainly hope that the tool will be used widely, both by organisations who engage or support NDIS participants, as well as those that work with people with disability across Australia. Finally, I'd like to thank the Monash team. It's been a pleasure working with you on the index, and we certainly look forward to seeing it being used for the benefit of people with disability in Australia. Thank you, and I might hand back to you, Dennis.
Thanks so much, David. So next, we have Professor Anthony Harris. Anthony's the former director of the Centre for Health Economics in the Monash Business School. His research has included several econometric studies of the healthcare system and the measurement of health outcomes in health and disability. He's been the leader of a team evaluating medicines and other health technologies for Australia and Singapore governments since 2001. Before he starts, I'll just remind people to put their questions in the Q&A. So the button's at the top of the screen. So feel free to put them in during the talk as well. Over to you. Thanks, Tony.
Thanks, Dennis. I know everyone's very excited. I hope you are to see the new DWI, and we will present it in just a few minutes. But I just wanted to start by putting it into some context, some reasons as to why it looks the way it does. As David had said, this started out as a project for the NDIA, who are interested particularly in looking at value for money and the performance of the system. So what we hope we've created here is a holistic measure of well-being for people with a disability that's got a particular set of design parameters. We designed it to measure and report on how well people generally do with a program or set of services that they receive. In other words, we didn't design it as a measure for tracking individuals as such, but more to look at the way in which programs are performing. And we designed it to look generally, not specifically at particular individuals in some category. And the reason for that is we wanted it to be able to allow routine reporting of how programs of service and supports are affecting people's lives, hopefully improving people's lives, and whether or not they offered value for money. We also wanted to allow it reporting of differences between groups, inequalities and outcomes by type of disability, by rural and remote or metropolitan. And what we need for that really is a common measure that's capable of reporting outcomes across all these groups. So it has to have something which is capable of doing something measurement in common and not specific to an individual. So what we have produced is a so-called global measure of well-being. That's to say something that focuses on some total measure of your well-being, the satisfaction with your life, your happiness. So it's not satisfaction with the inputs or processes. Many measures that are available now look at how happy you are with how well people are producing what you're receiving. Are you happy with the NDIA? Are you happy with your provider? That's not what this is about. This is rather about how these things translate into having a better life. And what we've designed it to do is reflect the views of people with a disability and their views on the relative importance of aspects of their life. So whether something is more or less important than something else is what we've called a preference-based measure. The other thing, given this is going to be about, we hoped, measurement over time and between programs, we wanted something that was concise. So relatively small, easy to understand, easy to collect, but still covers the main aspects of well-being. So that's the main challenge. We wanted something which was relatively easy to put into the field, that people would find easy to read and fill in, but still manage to capture the main things that affect people's well-being if they have a disability. Now that's a bit of a challenge because obviously some things you might think are missing, some things are summed up and aggregated, but we'll talk about that perhaps when you see the instrument. And the other aspect of that is you don't want to reduce it so much that it's no longer a reliable or valid scale. What I mean by that is we needed a scale that would actually measure differences in well-being. So if we see people who have different levels of well-being because of the service that they receive, or there's a change in the service, so there is a change in the well-being, we need that instrument, this index, to respond to that, to show a difference in the number. So that's also something we aim to achieve in the way in which we've designed it. So generally then we want a measure of well-being which is broadly applicable for everyone with a disability. Now that's going to be very difficult, and so far we've designed a measure for adults and one for young people. We've designed it so that it's indifferent, if you like, between location, to some extent age within a range, the kind of disability that someone has. So it's broadly applicable. Nonetheless, as we'll see and discuss, it won't necessarily be applicable to all groups, and that's perhaps for the future. For example, it may not be suitable for children because we haven't developed a measure for children yet. But what we think is it's broadly applicable for most groups, and it may well be applicable for groups we haven't really considered. Thank you. I'll let Gang now talk about, back to you, Dennis, and Gang can talk about the instrument.
Thanks, Tony. So next we've got Professor Gang Chen. He's a professor at the University of Melbourne and the Peter MacCallum Cancer Centre, and he's also an adjunct professor at the Centre for Health Economics and the Monash Business School. He's a chief investigator on the NHMRC CRE in achieving health equity for all people with disability. As a health economist, he's made significant contributions to the measurement and valuation of quality of life and subjective well-being for economic evaluation, as well as to the design and conduct of novel health preference research. Over to you, Gang.
Thank you, Dennis. And good morning, everyone. I'm Gang Chen. I'm a middle-aged East Asian man with black hair and glasses, wearing a dark suit and a light shirt. As Tony just mentioned about the motivation for developing disability well-being index. So in this section, I'll briefly take you through the whole process of the development. But to begin with, it will be great to looking at what the DWI, the final instrument, looking like. So if you have been using the quality of life instrument or health-related quality of life instrument, you will notice that there are a lot of similarities. So it has one of the what we call classification system, which is the questionnaire, as well as the associated scoring algorithm. So, but there are also some differences. So onto these slides, it shows the concept mapping between the DWI as well as two key disability-related outcome framework, Australia's Disability Strategy 2021 to 2031, as well as NDI's outcome framework. It shows how the DWI overlap with two key documentation. And that likely to show what the key difference, as you might observe as compared to other quality of life instrument, is that it has covered a broad well-being domains that goes beyond health. So health is in the middle. There are two items. Each covers physical health and the other covers mental health. Beyond that, we have the other 9 items, 9 aspects that align with the two key outcomes framework. So that will be, I would think that will be the key difference with regarding to the disability well-being index, is how it covers on different areas of people's life. On the website, which we're going to be introduced shortly later, you will be able to download the detailed questionnaire, the user guide, and it is free to be used by anyone. So I wouldn't go through too much of the details, but I will briefly mention a few key things. First, we have been developing the questionnaire into 2 versions at this stage. The first is the standard version, and the second one is easy English version. So standard version looks like on the screen, so it can use in a hard copy format or in a survey we conducted quite recently. It was programmed onto the survey program platforms such as Qualtrics. So the formatting will be flexible. With easy English version, we have received a lot of support, and in fact, this is designed by Valid, based on the standard English version after a lot of other consultation. So the easy English version look similar on the screen. It has basically the same items, but the way the item was being presented, explained, slightly different from standard version. As Tony mentioned, that we aiming to have a relatively concise instrument, which will not pose a lot of response burden, but we also wanted to cover the common life aspects that matters to different people with different type of disabilities. So this on the screen shows 10 key areas, life domains or life aspects in which described using 14 items. We consider quite a bit different of type of response levels, intensity scale, frequency scale, and also we hear a lot of feedback from people with disability. So at the end, we ended up with 5-level response scale on this table. To the right-hand side, it shows it ranks from all of the time all the way down to most of the time, some of the time, a little bit of the time, and none of the time. So the exact description of the items is as shown on the table, although we have some explanations to give it for some of the items. So you can find all the details onto the website as well as the user guide. I'll give a couple of examples. So for example, this is a DWI item onto safety. So we have a statement, I feel safe in my life, and followed by the 5 response levels. And also, after completing the questionnaire onto the items, we also provide some suggestions. For example, if respondents selected relatively lower well-being level on a particular item, in this case, feel safe in my life, some of the time, a little bit of the time, or none of the time, we would like to provide some information for respondent to consider. That could be help. So there will be present as a series of box in the questionnaire. If it's online survey, we can program that into this box will be automatically shows up after those options response levels being selected. Here is another example onto mental health, and this is easy English version. So as you can see, the items has been phrased slightly differently, also with images to support. So are you happy with your mental health? And mental health is about what you think about and how you're feeling, like happy or sad. Similarly, if respondents selected a relatively lower level on the well-being of the particular level, we will have additional supporting information to be presented to the respondent. So after completing all the 14 items, we will be able to calculate the overall DWI index. So the DWI index is if you think about this as a scale, range from 0, which represents the lowest well-being, and 1 presents the highest well-being, which is defined by the DWI questionnaire. So in the current scoring algorithm, if you have the best levels of all 14 items, you attain a score of 1. On the other hand, if you have the lowest levels being ticked box, you will be assigned a lowest well-being level of 0. So as a note, this is the 0 here difference from some of our commonly used preference-based health-related quality of life instrument. In those cases, 0 likely to be anchored onto death. Here, the 0 represents the lowest well-being level defined by DWI. And to calculate the score, in this case, we will just need to add in this value from each of the 14 items. So here, as one example, if respondent choose the second top level most of the time for all 14 items, and the overall index will be calculated as adding each of the value attached to the relative corresponding level of the items together. Here, 0.9193. So if you think about using the instrument to measure the intervention impact of the intervention, you might measure the score at the baseline or the pre-intervention. And assuming you will observe a positive impact, you are likely to measure again in the post-intervention phase. So you will be able to understand the impact on well-being from a particular intervention. On the other hand, if you go through the menu or the user guide, you will see there is also an optional section. The optional section is aligned with each of the 14 items, in which we ask respondent to rate individually to what extent each life aspect is important to their well-being. So here, for example, you're looking at a learning domain, so learning new things as much as I want to. So respondent could provide information about whether learning actually plays an important role in their well-being or not. So based on this optional information, if collected, you may be able to calculate an aggregate importance weighted score for the respondent. So, but this is not compulsory. You will adding the second set, which will another 14 questions, will provide you rich information to understand what matters more for each respondent. On the other hand, it will potentially increase the length of the survey, so potentially response burden. Similarly, it will have easy English as well. So that's about the DWI itself. And very briefly, I'll go through some of the key stages that we have been went through to develop the DWI. So it is multi-stage, multi-step project. In stage one, we're looking in particular at the classification system for the DWI. That is to say, the questionnaire for the DWI. In the stage two, we're looking at developing the algorithm, the scoring algorithm, which we used a method called discrete choice experiment, which has been quite widely used in health economic literature to understand the value respondents place on health, on well-being. Now I think it will be stage three. We would love to see it launched and to be implemented, testing, as well as to refinement. So you will be able to find the detailed report as well as appendix on the DWI website today, and it will be freely downloadable. So please feel free to go to the website if you are interested to know more about the detailed process. Very briefly, that in stage one, that's how we started. So in the stage one, to construct the questionnaire, we have go through 4 key steps. In the first step, we went back to the NDRS short form questionnaire to explore its performance, as well as the potential items that shows good performance that could be potentially used in the way to construct index. In the step 1B, we go beyond the NDRS documents to broad well-being framework globally, as well as recent developed health-related quality of life, as well as health and well-being questionnaires. So we try to understand what are the key items has been developed, has been used in the quality of life literature. So adding all the information together, we will be able to produce item bank, which can also be found on the appendix of the report. So based on those information, we're working with a small group with a lot of experts in the field. I wouldn't name everyone, I just really acknowledge the support we receive along the way, that we be able to narrow down to a set of candidate domains as well as items underneath each domain for presenting to stakeholders for consultation. So before the step 2, we're coming out with the manageable documents and we bring to the stakeholders for consultation. This is a busy slide. I'd like to keep it because there are many, many people, organizations, policymakers that have provided their feedback along the time. I wouldn't read all of them, but that's the first step when we're starting. So we have 22 NDIS participants, 5 carers of NDIS participants, 12 disability organization representatives, and 12 government representatives. So they all contributing to the stakeholder consultation process. They provide the documents, the motivation for the development, and then they are invited to provide initial comments on any of the life domains that may be matter, but is missing, or some of the items that may not be necessarily included from the list. So the format will be the focus group discussion. For policymakers, is typically one-to-one interviews. After the interview, there will be also the second opportunity to provide additional comments, as well as a third opportunity in putting feedback in the very brief follow-up survey. After step 2 is complete, our team based at University of Sydney more likely to talk about this section shortly, that lead a separate qualitative studies. So in this phase, it covers both adults and young adults. It also conducted separately between adults, which here we define as 25 years and above, and the young adults, 15 years to 24 years old. So 80 participants participated in the consultation, in the qualitative studies. We also have value to help with 2 of the focus group discussions. The one group with intellectual disability and one group with diverse disabilities from regional Victoria. There are additional well-being domains or life aspects being mentioned by people with disability that were not included in the current DWI exactly. So these will be the domains potentially future study will also could be considered. I wouldn't read it out, but it will be including such as identity, cultural connections, travel, communication, your future goals, hope, future security, medication, resilience, system interaction, etc., etc. There are also some of the well-being domains in which we initially considered, based on the literature, that are likely to have a large impact to the well-being, such as achieving in life, self-worth, which was not included later on. These were also based on the feedback from the consultation process that people raised the concern that asking these questions could be potentially offensive to people with disability and potentially will bring more harm than good. So we did not include in some of the initial domains into the future phase. So this graph pretty much shows where we're starting from. The purple part contains 8 outcome domains, including in the NDI's outcome framework. The 4 blue box underneath the purple one, it shows what we initially included from the literature as the bottom dimensions. So this consistent of the original consultation stage. Whereas after the stage 2 and 3, we narrowed down to the 35 items to the right-hand side that we bring onwards to the quantitative testing. So that's where the step 4 covers. So we're trying to understand the performance and the relationship of these 35 items. And from them, we're trying to select the key items to be included in the DWI. We have 2 cohort surveys sent out separately because we would love to understand the performance within each cohort separately. So we have 728 adults and 205 young people provide sufficient information to be analyzed to be included in the study. So those are shows on this table. To the left shows the adult sample, to the right shows the young people sample. So to be noted that typically the respondent will select more than one disability group in the survey. So the area highlighted in green, you wouldn't add up to 100%. So it covers quite diverse of different disability groups within each of the cohort. After collecting the quantitative data, we go through the next step, in which case we're trying to select out of 35 items what will be the key item to be included. So that goes through a few steps, which is shown on the current graph. It's highlighted in the first phase, we're purely looking at the psychometric properties. So for example, we're looking at each item's performance, such as likelihood to have a missing value, which probably means respondents don't know how to answer the question, or it's not applicable, or people will say not applicable, or likely to have a ceiling effect, which probably means you wouldn't have more chance to improve on particular items over time. We're looking at a small group respond the survey twice, so looking at the test-retest reliability, and we're looking at the item performance using rush analysis, looking at the response disorder as well. In addition to that, we're also looking at how each of the items that could influence on the overall well-being, which was measured using a single item or another validated instrument. So we're looking at the importance of each item or a group of items explain the overall variation of the well-being or life satisfaction. So that gives us a sense about the importance of each item in explaining well-being. We're looking at the item structures of the lab about different life aspects that initially was asked in different life domains. So based on all those information, we're coming out with a set of potential options to be chosen as the key items. We bring back to the NDIA for the policy, for the policy makers to review, as well as to people with disability, to looking at the outcomes from psychometric property and to provide some feedback. The second stage is quite relevant in this case, in that sense that, for example, the work as a key item has a clear policy relevance. However, if you're purely looking at the psychometric properties, such as importance, it was one of the items that people likely to rate as not important as compared to other well-being domains on the list. But it had clear policy relevance, so we included it at the end. Also, we also received the feedback from NDIS participants talking about their well-being change after including in the NDIS, how that will change on their work domain. So they will respond differently. So this gives us additional information, not purely from psychometric property, onto the selection of the final 14 items. So this is a similar graph as I showed early on. It shows how the overlapping between DWI as well as the other two disability outcomes framework. So after the classification system being done, we're working on the scoring algorithms. I wouldn't go through this in detail, but it is one of the steps that typically we will do for the preference-based instrument. As a strong assumption for the non-preference-based scoring algorithm is that you will assume all life aspects will play an equal role in your well-being here, or would say equally important. Whereas we know that typically not the case. So we want to relax this assumption. So it is done using a method called discrete choice experiment, which is a choice questions. We present hypothetical scenario for respondent to choose. In this case, because we got 14 items, it does cause some challenging to present all 14 items at once to people with disability. So we use a particular design to only show part of the well-being profile to the respondents, whereas assuming all else are equal for respondent to choose. So based on a series of these hypothetical scenarios, we are able to understand relative importance about each life domain as well as response level to people with disability, their well-being. So we have 1,470 adults and 513 young people provide sufficient information to contributing to the analysis. So that's the end for my part. I think really just want to thank everyone again who contributing to our different surveys, this voluntary survey. So really thanks for them to sacrifice their time to provide this information. Thank you, and back to you, Dennis.
Thanks, gang. So next we've got Associate Professor Kim Buckley, who is co-head of the WHO Collaborating Centre for Strengthening Rehabilitation Capacity and Health Systems at the University of Sydney's Centre for Disability Research and Policy. She has more than 30 years of experience in the community disability sector in frontline management, policy and research roles. She's a senior academic in the occupational therapy discipline, promoting critical disability perspectives and the inclusion of lived experience educators. So Kim's going to be talking a bit about accessibility issues and the importance of including people with lived experience in the process of trying to put together the DWI. So I might throw over to you, Kim. I can't see your video.
Thank you. Oh, yep. Am I there now?
Yes, and now. Thanks.
And you can hear me. Thank you. Okay. Thanks, Dennis. I'm a short woman with grey blonde hair that's curly. I'm wearing glasses and I'm wearing a black and white top with an ochre coloured scarf. So I was delighted to be part of this team, and the Sydney team from the Centre for Disability Research and Policy was really asked to do engagement with people with disabilities. So Gang spoke about the range of consultation approaches, which included engaging with organisations. The Sydney team really focused in on engaging with individuals. So we brought together a really strong team and had 3 sort of purpose-built teams for the different phases that we were involved in. So we were mainly involved in stage 1, which was around the item development, and then stage 2, which led up to the preference weighting research approach, which then informed the stage 3 actual trial. So we were less involved in stage 3. We also really leaned in heavily to our colleagues at Valid and the Centre for Accessibility, who really gave us very expert advice in particular aspects of engaging with people with intellectual disability and with a broader range of disabilities. The next slide, please, gang. Just to also refer you to, we have detailed reports on all of those stages available on the DWI website. Obviously today we can't go into that in much detail, but all of the reports on those stages are available on the website. So this item development phase, we really made sure that we had a research team that included people with lived experience of disability, so that we were really prioritising that lens and getting that perspective both from our research team and from the research participants. So all focus groups and most of the interviews included a researcher with lived experience of disability. It was a great team, and we really found those diverse perspectives really enriched our conversations within the Sydney team, but also then with our colleagues from Monash and Flinders when we were discussing the item development, because it was a huge process of working with existing items and instruments and outcomes frameworks, but then making sure that we were incorporating the perspectives of people with disabilities in that conversation about how to wrestle with those items that were already there. So we weren't starting with a blank page, but we were certainly making space for perspectives and insights from individuals with disability that we spoke to as our part of the research. So it's certainly, a broader approach to this. It's not just for NDIS participants, but we did certainly include NDIS participants in our group. So we spoke with 80 people, as Gang indicated before, both adults and younger people. And we did find that there were different perspectives from those groups and different life areas that people had more of an investment in at different life stages and phases. So that's been considered in the item development for this instrument. We were also aware of the terminology that was being used. Domains is a very common term that's used in this area of instrument usage and development, and that was really not well welcomed. So life areas is something that we have now moved into using. Of course, that still exists in many other instruments, so it's referred to throughout our presentation, but the actual instrument doesn't use that term. The time frame for answering questions and the response levels took a lot of discussion and focus from people. So that was something we really considered about what was the most useful framing of, is it now? Is it over the last 6 months that you're considering answering these questions? So they were really rich discussions. And so that, we landed on a now, and we landed on the 5 response levels that Gang walked through earlier. Another area that came up for me that was really important for us to consider, and we're still needing to work out how we do this, but Gang showed you some examples of safety and recognising that safety in completion, things being triggering, etc., are things that we really need to consider in these wellbeing indexes or frameworks that we are engaging with people around. So making sure that there is ways of supporting people when they're going through these conversations and pointing them to resources that can help them if they are needing additional support from being triggered or feeling unsafe, and notifying that when you're completing these indexes. There is a clear need for accommodation for completion, and we felt that that was something that was very strongly identified in those earlier conversations. So our second phase that was led by Kieran Howe, was really understanding how we had to look at accommodations. So that involved consultation with 16 stakeholders from organisations, particularly looking at accommodations in survey completion and how we could do that as well as possible. And so there was also a report completed by the Centre for Accessibility. So this was really focused on the options that are available. So, for example, screen reader, Auslan videos to introduce the index, but also for completion, so options for how people could access those things, and that they need to be a standard offering. They're not something that is added on at the end. We need to be considering that up front. We also heard very strongly that for a wellbeing index about your internal state of wellbeing, proxy completion is a last resort. And a reiteration about the sensitivity for potential items to be triggering and the recognition of safety of respondents. So in building that into the design of the survey was highly recommended by these groups in this phase. Go to the next slide, please. So the DCE survey, so the Discrete Choice Experiment Survey, presented particular challenges for us as a research team. The survey, again, showed you some examples of what that included, meant that people were having to do comparisons and trade-offs. So it was a very complex system of questions that people had to answer. And so that was something that was really problematic for some people who had particular accessibility needs, for example, using screen readers or having to recall information and respond to it. So there was a real awareness of the challenges that DCEs present for us as researchers in using that method when we're looking at people with a variety of accessibility issues. So our team was particularly focused on developing a distress protocol so one of the options we came up with was for the team to support people in completion of the DCE survey. So we needed to have a way that we were all on the same page about how we would support people if they became distressed. We developed the standard online version and then an online easy English version with Valid that you saw again showing some examples. There was also hard copy versions for both standard and easy English that could be sent to people if they had issues with accessing things online. And we were really aware of screen readers and the platforms that we used being as compatible with screen readers as possible. And then also the optimised voice to technology users was so important. So we also looked at offering telephone and online completion options with a member of the team. And for people who, for example, were Auslan users or who were needing some support to understand the survey questions and they were asking for assistance with that, they didn't have somebody who they wanted to have that done with in their own environments. So that safety and survey completion in a safe manner was again reiterated here when we were doing the DCE survey. The final slide, gang. So one of the things that came through loud and clear for us is about self-completion as opposed to proxy completion. And so we feel that as researchers, but also as people who are delivering or providing a platform for the delivery of this index, that we really need to continually strive for better ways of having self-completion for this index. So that we are really capturing the perspectives of the person with disability about their wellbeing. And then this hierarchy of some supported completion. So again, where the focus is on capturing the perspective of the person with disability, but perhaps assisting them in some way in recording that that response, and that proxy, so where somebody is completing it for the person with a disability, is the last resort. So we've got some challenges to continue to improve that, but we recognise that that's our aspiration. Thanks. I'll hand back to you there, Dennis.
Thanks so much, Kim. So again, yeah, so really important accessibility issues that need to be considered when, implementing the DWI, and also, further considerations for further developments that need to happen. Next, we've got Dr. Samir Banerjee. She's a senior health economist at the Centre for Health Economics. Her research aims at improving policies that affect the healthcare use, health and well-being of people with disability and their carers through the analysis of very large and complex linked data. Samir has worked with several government and non-government organisations, the World Health Organization, Department of Social Services, and the National Disability Insurance Agency on small and very large scale cross-disciplinary projects. Thanks, Samir.
Thanks. And this is one of this project, and it's been my pleasure to work on this project. I have long dark hair, I'm wearing purple glasses, and I'm also wearing a pullover because I'm speaking from now Melbourne and it's been a bit cold. So I want to talk about how the Disability Wellbeing Index compare to another instrument that's established and well used. It's the Social Care-Related Quality of Life Measure, the ASCOT, which stands for Adult Social Care Outcomes Toolkit. The preferences were derived from the UK, so this means that the different weights you assign to the different questions and level were based on answers derived from the UK population. So this is ongoing work, by the way, which is led by your next speaker, Ghost Day. And so basically in 2024, we collected responses from both instruments, and this allows us to compare the two instruments and see how well they're doing. And both instruments, as you know, for DWI at least, include an easy English version, which I think is referred to as easy read for the ASCOT. We found substantial overlap between the two constructs. So even though they differ in their conceptual framework for being developed, I mean, ASCOT is more about social care. The Disability Wellbeing Index is more about the subjective well-being global measure. So how do we know that? So we've done some exploratory factor analysis. Then we've also checked what we call non-group validity, which is about basically checking your instrument is measuring well what it's supposed to do. And the idea is that self-rated health, decision-making autonomy, free time autonomy, and self-advocacy. As these increases, you should have a higher score on average, controlling for other factors. And we found evidence of this validity for the DWI, as well as the ASCOT. We just did them together. Can I have the next slide, please? In this slide, I'm presenting a graph. So on the vertical axis, it's the score of the ASCOT. And on the horizontal axis, it's the disability well-being score. And there is a green light that shows how the two score would be correlated if they were, measuring exactly the same thing. And then each dot on my graph shows the score of the ASCOT for one person and the score for DWI for that same person. And so if you can see the different dots on the graph, you can see that the two measure, the disability well-being and the ASCOT, they're positively correlated. But as you can see there, the dots are not on one line, so they're positively correlated, but they're not measuring exactly the same thing. You can also see that there's a lot of points on the one line. So at the very, very top, this is because this seems to be a little bit of a ceiling effect with the ASCOT, which you do not have with the DWI, because if you look at the one on the horizontal axis, you don't have this issue of, not being able to measure improvement above a certain level. If you look at the correlation between these two measures, you would find that this is 0.73. So the graph I'm presenting is on the standard version, not the easy English version, with both the young people and the adult people pulled together. If you just focus on the young people, you will have a correlation that is also high, but maybe we would call it moderate. The convention is 0.7, but you can see it's pretty close. 0.66 for young people, 0.61 if you were to use the easy English version for young people, and for adults you can see the correlation is strong at 0.75 for the standard version or 0.74 for the easy English version. So yeah, so the two are well are measuring well the same thing. And if you want more information, Guzde is presenting an extended version of this at the AHES conference. Thank you.
Thanks, Samia. So yeah, so I suppose the disability wellbeing index is very closely aligned with other measures. In terms of the ASCOT, I suppose it probably was developed more in the social care space, more in that kind of aged care space. So maybe it's not surprising that it's doing slightly better for adults than it is for young people. Next, we've got Dr. Gozde Aden. She is a research fellow and project manager of the Disability Wellbeing Project. So often when you send emails to the email address, it will be Gozde who will be responding. So be kind. She's also the NHMRC Centre for Research Excellence in Achieving Health Equity for All People with Disability project manager. Her current research interests focus on co-design in health settings, quality of life, and health preferences. She also works across several national projects that contribute to the development of evidence-informed policy and practice in the disability and health sector. Also, just one bit of housekeeping. So the Q&A is working for some people, but not for other people. And the chat's working for some people. So make sure you put your questions into either the chat or the Q&A, whatever's working for you. And if neither are working, send an email to dwi@monash.edu. Over to you, Koste.
Thanks, Dennis. Thanks for the intro. And it's so great to see so many people online today. I can add that I'm a woman in my late 30s with long brown hair and brown eyes. And today I'm wearing a black shirt. My presentation will mainly focus on how you can access DWI versions, user guide, and the related resources, such as the DWI project reports. They're all located on our dedicated website. Therefore, I'll take you to the DWI website for a quick walkthrough. I already have a pre-recorded video for this actually. Can you please play the video again? Actually, I can't hear the sound. Can you also hear the sound? Maybe I can give you a live walkthrough.
Yeah, I think you're gonna have to give a live walkthrough, Koste.
At the bottom of the homepage, you are going to find our accessibility statement. This statement will produced by Centre for Accessibility Australia. And then you can find our contact details at the right bottom of the homepage. It's dwi@monash.edu. We are going to do our best to reply you as prompt as possible. If you go to the top of the website, you're going to see some tabs. Maybe if you play the video again a bit further. The first tab you're going to see is the About tab at the very top. It includes some information about the DWI project and the research team. The next step, Instruments, provides some brief information about the DWI standard version, DWI Easy English version, and user guide, but you cannot download versions or the user guide from this tab. The next step is Resources tab, where you can find DWI related reports and publications. We don't have any publications yet, but we are working on several. So once they become available, we are going to add these publications to this website as well. The next tab is Frequently Asked Questions. Under this tab, we included some questions we could think of, but I think after today's session, we are going to add more questions. the ones that are asked during the session. The next step, register, is the most important one. Can you maybe play a bit further? Okay. So when you click on the register tab, you need to answer some questions if you want to access DWI versions and the user manual. After submitting this form and answering these questions, you'll be able to see a button to download the versions you are after and the user guide. We want to have a sense of how DWI will be used and by whom. That's why we are asking some questions to the people who want to download DWI. So today's recording and slides will be also available on the DWI website. So that's all from me, I guess. I'm happy to answer any questions in the Q&A if you have any for me. Thank you so much.
Thanks, Kosday. So we might go to the next slide, gang, if it's possible. So yeah, so I suppose this kind of wraps up the presentation part. So I suppose just in summary, I suppose measuring and monitoring outcomes that matter for people with disability is critical to help us improve services and supports and guide future policies. And so we've developed this world-first wellbeing measure with and for people with disability, Disability Wellbeing Index. And the Disability Wellbeing Index is free to use and publicly available. I suppose, we want the most number of people to use it as possible. We think it's valuable. We hope that it'd be widely used by those providing services and supports to people with disabilities, both within the NDIS and more broadly. So we do think it is applicable outside of NDIS participants. What we would say is that, this is version 1 of the Disability Wellbeing Index. It's the start of our mission to better measure and monitor outcomes that matter to people with disabilities. We'd welcome collaboration with others to help us continue to improve the measurement of outcomes. So thanks again for your participation. We're going to now move into kind of a Q&A session. So thanks again. So you might want to note the website and the email address, and I'll get all the speakers to put their cameras back on. And gang, I might get you to stop sharing the slides. So again, add your questions to the Q&A or the chat function. I might start by posing some questions to people. So we might just start with a question.
I think she has made a list of questions, and there was a question very early on about whether we use the framework, and I think the implicit question was about whether it can be applied to Indigenous people. If Gang wants to answer this one. Sure.
So I suppose it was like, to what extent we considered the closing the gap framework. Gang, I don't know, do you want to make a comment on that?
Yes, thank you for the questions. So I think in the current state, it has not yet been tested and among First Nation peoples on the Disability Wellbeing Index. During the initial development process, we invited and involved First Nation people into the process. As I can record, into the survey, we roughly have 4% of total respondents. So I think further development testing will be definitely needed for DWI to be more confidently used, or maybe that should be substantially improved.
Great, thanks, Gang. I suppose there were a couple of questions about, use of the DWI in the general population, and also potentially, can the DWI be used in people who might have a temporary disability, or people who might, have had an accident and are recovering. Tony, I might throw it over to you. Do you want to tackle that one for me?
That's a particularly difficult one. The short answer is we're kind of agnostic about when it can and can't be used, in the sense we've created a wide index which we think will be reasonably sensitive to most situations, but time will tell whether it will or won't. I see no reason really why it couldn't be used for programs that have a short-term outcome. So the questions are suitable for that. Clearly, it won't cover everything. There may be some particular programs where the outcome is very specific and it's not reflected in some of our measures, but I'm not sure what those ones are. So I think time will tell whether it will be suitable for everything, but we think it's a broad-based measure that's suitable for most situations.
Great, thanks,
I don't know if
Tony.
that answers the question, but
Yeah, I think you did well. I might ask him the next one. How were participants recruited to engage in the qualitative components? So maybe you can answer from the Sydney side.
Yeah, yeah. So in terms of individual participants, we put it out broadly through the disability persons organisations, as well as our own networks, and through and with assistance from the NDIA, putting it out to their panels as well. So it was quite a broad range of options that were used to try and recruit a diverse group of people.
Great, thanks, Kim. I might also follow that one up for you as well about, I suppose, like, there's a question about, in particular, people who might have, cognitive barriers to being involved. And I suppose, these other hard to reach groups, I suppose, the question is, how did we or did we get them involved in those stages, or is there more to be done there? I might ask you that question.
Yeah. So we did lean into Valid was an organisation that we used to support us with engaging with people with intellectual disability particularly, but we also did recruit people into our other focus groups. It wasn't just the Valid focus group that addressed people with intellectual disability and cognitive limitations. Look, I think we got a reasonable diversity. Could we do more? Yes, I think so. There's a a range of voices that we didn't hear. We did not recruit many people or any people who used Auslan who identify as deaf in our broader focus group and interviews. We did reach out to then some individuals that were within our networks to try and address some of those gaps.
Thanks, Kim. So I might switch to a question about the level of accuracy in the individual overall score. How many decimal places are to be used? Like, how far should we go? I don't know, Gang, do you want to have a go? What you think in terms of how accurate the measurement is?
We currently, as a scoring algorithm, we use 3 decimals, and but that's a good question. I haven't think about what would be making that would leading to a big difference if we're using 2 or 1. But I would say by default you have 3 decimals to be calculated.
Great. I might follow up, Gang, about, can it be used in like a cost utility analysis to try and evaluate the value of particular services supports or, policy changes?
Yes, thanks for the question. Yes, similar to cost utility analysis, in which case people typically calculate quality adjust life years. However, I should make a note here that because there are one thing is a bit different as comparing to the preference-based quality of life instrument is the anchoring point for the 0. In which case, in the cost utility analysis, while the utility typically have 0 anchoring at death, whereas in disability well-being index, the 0 is representing the lowest well-being for defined by 14 items. So that's not equal to death, that's not equivalent to death in this regard. So the results wouldn't be directly comparable. So our Flinders team, which led by Professor Julie Radcliffe, has done quite substantial investigation and exploration at the initial stage before we finalize in the DC study. We think about whether to also having this step to unclean the well-being to be the death, 0 to be death into this value set. There are several challenges, not to the only the methodological way that they got 14 items to begin with, but the concept of having unclean and death was not well received among the consultation process. So we did not including that. So please bear in mind, this will be the key difference. But if you're looking at broadly on well-being literature, for example, if you're looking at the capability well-being, it is also initially that the 0 will be the lowest capability well-being. That's not necessarily the same as what we typically use in the cost utility analysis, such as preference-based instrument. So just be alert on that.
Thanks, gang. I might throw to Tony, like, how do you see kind of the DWI working alongside other national disability surveys or outcome data sets?
Well, ideally, one of the things with the DWI is we'd really like to see it, I guess, in practice tested on large data sets so we can see whether it fulfills its promise of being a responsive measure that produces outcomes that reflect people's changes in their disability. So it's relatively small, and I can see it could fit quite well into routine surveys that are done on disability. It wouldn't be much of an imposition. It would sit quite well alongside other measures. As I said before, it's not going to measure everything, and therefore I think it's got a role to play as an adjunct to other measures that are more, if I could call them clinical, are more related to how individuals' life is changing with specifics. So I can see it being used in broad surveys, longitudinally repeated, because it's a relatively neat measure, if I could use that word neat in terms of its size and also its quality. But I can also see it being used in more specific data sets where people are interested in more detailed outcomes, but this can provide people with a kind of global well-being measure alongside that. So I think it's got multiple uses. And obviously, we'd like to see it used extensively, and we think it's suitable in a wide variety of circumstances. That said,
Thanks.
we'd like to see it tested a bit more in those, just to see how it goes and whether it could be refined. Because this, as you said at the beginning, is version 1, and there's no doubt that there's room for improvements, both in the content and, as Kim said, in the way in which we deliver it. Yeah.
Thanks, Tony. So Kim, there was a question about gaps with the deaf community and whether they're going to be addressed. Yeah, so I suppose I don't know whether you had thoughts or comments on that.
Yeah, no, we recognise that as a limitation. Like, we endeavoured to have options that included, an Auslan invitation, for example, but we didn't get the cut through into the community that we were hoping for. So we certainly need to have a bit of a think about how we can partner with people going forward to address that and recognise that as a limitation of the current version.
Great, thanks, Kim. And so I suppose there was another question about, is this only for survey settings or as part of routine administrative evaluations? I might throw this one, David, to you if you want to try and have a go at tackling it. What do you think about, survey settings only or more, routine administrative evaluations as well?
I guess from an agency perspective, it could be both. Yeah, I mean, I think we do need to look at it alongside participant outcome surveys that we currently have, and revised outcome surveys that we might use in the future. But certainly our evaluation activity and others' evaluation activity as well could certainly, I think, utilize a DWI.
Great, thanks, David. Tony, I don't know whether you had thoughts as well about, whether or not it's just survey settings or how widely are we talking about?
The original conception, I think, was that it could be used routinely to measure performance by agencies or providers, and not just the NDIS, but more widely than that to the majority of people who have a disability or not on the NDIS. I think people could use it as a performance measure for services, both providers and also funders, whether it be NDIS or others. So I don't think it's necessarily, and we didn't suited just for surveys, and that wasn't the original intention. I think our original intention was it was a program evaluation measure, and therefore it could be used for one-off programs, but also for more routine programs. And also, if it's collected more routinely, it allows you to evaluate new programs as they arise without designing a specific survey for that. So if it's collected by your agency or your provider, anything new that comes up, you've immediately got a means of assessing whether it's promoting well-being amongst people with disability or not. So yes, I see it as more of a ideal for a routine measurement.
Great, thanks. I might throw this open to everyone. There's a question from Caroline. Will this paint a picture of inclusion and capture if a person feels safe, but also strong? Will it capture people feeling included in the community and actively participating? And if so, will this be linked to building a picture of connections that a person has, which might also contribute to articulating their natural safeguards? I don't know whether someone wants to have a response to that. I suppose, like, my initial response would probably be that it's going to partially do that in lots of cases. It's probably not going to fully illustrate all those things. I suppose, this is the kind of trade-off between trying to be concise and have something that, people can answer and getting a reflection of their well-being. But at the same time, by being concise, it means that you can't dig into every aspect of someone's life as well that are often really important to them as well. So it's definitely trade-offs that we had to make, and had to make some hard decisions in developing the Disability Wellbeing Index. I don't know whether anyone else had any thoughts. Kim?
I guess I might just throw in a thought here that I think that this is that sort of high level measure of well-being. And so it may be something that then highlights the need to dive into a particular aspect of somebody's well-being. So it might be about friends or work or, one of those areas that could then give more granular insights into inclusion in that broader sense. But this is about that higher level of a sense of well-being in those life areas that could potentially point to where you might go for a particular cohort of your service users.
Yeah. Thanks, Kim. I might throw this one over to Gosda. Is the DWI available in an online version? If so, what software platform is needed to host the online survey?
Yeah, actually, I answered this question under the Q&A, but we don't have an online version available, but you can build the survey on a platform such as Qualtrics if you want to use it online.
Great, thanks. I suppose another question maybe for you guys today. Once someone registers on the DWI website, will they be emailed the tool and user guide straight away, or is there a delay?
There is no delay. As soon as they submit the form, they're going to see some buttons. Once they click on the buttons, they can immediately download the tools and the user guides.
Great, thanks. I might throw over to Tony. How frequently can individuals complete the Disability Wellbeing Index? Like, what would you recommend in terms of, how often should you be asking people to complete these things? And does it depend on, what you're trying to actually look at measuring?
Yeah.
And good to get your thoughts.
Well, at the risk of just sounding like platitudes, obviously you don't want to overtax people, overburden them. So there's a limit how often you could ask it. You couldn't ask it every day or maybe every week. Could you ask it every month or every 3 months? I think reasonably every quarter, 6 months probably wouldn't upset people too much. As you say, it depends on what you're trying to capture. If it's a short-term thing, you're obviously going to have to measure it relatively quickly. Also, people's recall goes down a little bit and their well-being fluctuates somewhat. So you have to be careful that you don't get them on a bad day. And so you're biasing your result of well-being. So that goes to two things. One, you want to do it quickly enough after in between events, as Gan showed, when something happens and you get a baseline and then thereafter. But also doing it in a large enough sample means that some of those effects are kind of washed out. So this is one reason why it may not be that suitable for individual measurement of their well-being over a short period of time. But across a group of people, I think measuring every 3 to 6 months, it may well be you'll manage to wash out some of those temporal effects. So I think it's a trade-off, like all of them, between your capacity to collect it in a timely manner and not overburdening people. Personally, I think I might not like if I got this every 3 months, but I'm not sure how people feel. Again, it's an empirical question, really, that we probably need to investigate over time.
Great, thanks, Tony. I might ask Gosde you the question about, languages. Has it been translated into any other languages for multicultural people? You have to go off mute to deliver your answer.
No, not really. We just have the DWI standard and easy English version in English, but in future, maybe it can be something we can consider.
Great, thanks. Simi, I might throw you a difficult question, which is the work aspect. And I suppose, maybe you could just talk a bit through to the challenges of trying to, incorporate work into aspects of well-being, especially given that, so many people with disabilities that, that we spoke to, didn't kind of consider work as part of their life. Yeah, I don't know, it'd be good to get your reflections on the challenges.
You're getting back to the questions that was in the chat, and I think the question was what's going to happen if they don't have work? Will their well-being be de facto lower? Will it be applicable or not? So first, it's applicable. I'm just going to read the item so that it's maybe clear for everyone. The item is, I am satisfied with my work situation. And in brackets, we say not working, doing paid work or unpaid work. So it's kind of general, and it's about whether you're happy with the situation rather than whether you work or not. So this is how it will impact the well-being through how you feel about your work situation rather than whether you're working or not. And maybe someone else can extend on that because we worked on this version. We had different way of asking this question before. I don't remember exactly which ones we had in the 35 items. Then we tested 2 new ones. So don't know if you want to extend on that.
Yeah, so I might come in, and so I suppose work was probably one of the areas that we worked the hardest at in the DWI. So early on, we had versions where we got a large proportion who ticked not applicable for the question, and I suppose our aim was to try and minimize the number of people ticking not applicable, and so I suppose that's where we landed on the final version, which minimized the number of people who said that question was not applicable to them. And so this is kind of how we tried to also include those people who are not working to reflect on whether or not working was something that they were satisfied with, or whether or not actually they were not satisfied with not working, and they wanted to be able to make a contribution through paid or unpaid work. But yeah, Tony?
I was just going to add that work impacts on people's well-being not just directly, but through some of the other items on the instrument. So it's not being ignored in other ways. So it impacts through income, for example, in people's meaningful activity in life, which we also ask about. So in some ways, work is covered indirectly in the instrument. So I'd be less concerned perhaps than it might appear at first about the variations in people's work situation, recognizing that the sample we had of the NDIS participants isn't necessarily representative of all people with a disability, many of whom would be in the labour force at least part-time. So we recognise that the instrument needs to capture well-being across that whole range.
Great, thanks, Tony. I might ask Gang the question about does the DWI impose kind of a time frame, like a recall time frame over when people are evaluating their well-being?
Yeah, thank you. So I think we in the current standard version, we ending up to be how you feel about your own life as it is now. So in the development phase, King, I think, briefly mentioned on this, we have considered several versions, such as past 4 weeks, past months, or 3 months. We noted a lot of diversity among the respondents with regarding to the recall time frame. And so we, at the end, it's ending up to this particular version that align with several of the more well-being instruments. Having said that, I think this is clearly one area that could be fitting to the research questions and the particular intervention you have in mind to more refine what exactly will be the recall time frame you may be better to use. But in the current standard version, we use how you feel about your own life as it is now.
Great, thanks, gang. Kim, I might throw to you about a question about interested to know if it captures risk enablement and capacity building. Like, what are your thoughts around whether whether it captures it, whether it should capture it, whether or not, yeah, what are your thoughts?
Yeah. I mean, I think we certainly heard that safety was a key issue, and we were, trying to understand how we could incorporate that into this index. But in terms of people having risk enablement, I don't think that we've really been able to capture that, and that I really don't think it's a strong factor in this. Happy to be, disagreed with from other team members, but from my point of view, I don't think that was something that we were really able to integrate into our thinking about the items.
Yeah, so like I kind of agree, and I suppose it's more that I suppose we'd think it'd be captured in other items that actually being able to do things, and that restrictive element means that you can't do lots of other parts of your life that actually mean that you're not satisfied with those other parts of your life. And so I suppose we were focused on what you can do and what you're satisfied with in terms of those positive aspects, rather than focusing on those restrictive elements that might mean that those other elements in your life aren't able to happen. So I suppose we'd expect it to come through in terms of responses to the other items. David, I might throw to you. There was a question about how it is planned to be utilized within the NDIA, NDIS evaluations. Is there a planned implementation schedule in the broader setting? I know you probably, it's a tough one to answer, but yeah, maybe you can just kind of give us the general thinking and maybe the pathway forward that you're thinking.
Sure. I guess the short answer is we don't know yet. So there is no firm plan. So we're considering how to use the DWI, as I said at the start, in the context of our outcomes framework. And we are refreshing the outcomes framework currently, and that is a relatively long process. So we won't necessarily be in a position to kind of say anything for certain for another year or so while that outcomes framework refresh happens. But certainly there is interest and appetite for using the DWI either alongside or integrated with our outcomes measurement tools.
Great, thanks, David. So watch this space. We'll see what comes. Exciting new developments, hopefully. So I suppose we're out of time now, but I'd like to thanks you so much for coming, for listening to the presentation and the launch of the DWI. It's been great, all the questions that people have had. We might not have answered all of them, but again, send your questions through to the email address as well, and we'll do our best to respond. But yes, I'd just like to thank all the speakers. Well done. I think we've all got to work better at trying to communicate in simple language, but I think that's part of our goals, to be better. But yes, but again, thanks so much everyone for being involved, and I'll end it there. Thank you.